On behalf of this session, I'd just like to first of all begin by an acknowledgement to country. The Royal Australian New Zealand College of Ophthalmologists, members and participating guests wish to acknowledge the Aboriginal and Torres Strait Islander people of this country, sovereign custodians of country. We acknowledge their continuing presence and their contribution made to the college and the communities we work in. We respect past elders and communities and will continue to live, work and interact in a respectful manner with the present and future elders and communities. The Randscale Reconciliation Action Plan reflects the message of its First Nations engagement. Thank you very much. Over to you, Doctor.
All right, thanks everyone for coming down to our session. Today I'm going to talk about the patient journey, and this talk came about, I guess, over the past 3 years during a time of slowdown during COVID. Sort of had a chance to reflect and think about what our patients go through when they're diagnosed with ocular melanoma. And for a lot of these patients, they can be young and it can be their first kind of interaction with medicine and first experience as a patient. And they're dealing with a lot of uncertainty and a lot of unfamiliar testing. And that can be very stressful for patients. And so I put together some videos to sort of show what it's like to be a patient when you're diagnosed with ocular melanoma. And I think it can be translated across to a lot of other diseases in ophthalmology, but certainly the uncertainty and the prognostication that comes with this can be very stressful for patients. So patients in Brisbane are, patients from all of Queensland are referred to the Ocular Oncology service in Brisbane. We operate out of Terrace Eye Centre, which is a private practice, and we operate at the Mater Hospital, Brisbane, which is a public service. So we see referrals from ophthalmologists, optometrists, and general practitioners. Public and private patients are referred to the same private clinic, and billings are organised depending whether they're public or private. As the referrals come through, they're stamped with a date of receipt and they're allocated either urgent for things that sound very much like melanoma are seen within 1 to 2 weeks, things that sound like they may not be melanomas are seen within 3 to 4 weeks. Patients are then offered a clinic appointment. At their clinic appointment, they're given a diagnosis or potential diagnoses. Sometimes we can offer an investigation or biopsy. Treatment is discussed. At the same time, counselling is sometimes offered. And long-term, they're screened and followed up depending on their diagnosis. So this is a busy slide looking at cancer pathways. This is from Patient Safety and Quality Council in British Columbia. It's put together for patients with any kind of cancer diagnosis, and it was done through interviews with clinicians and patients diagnosed with cancer or managing cancer. And the busyness of it reflects how busy it can be to receive a cancer diagnosis. You can see there's lots of question marks here. There's a lot of long waits, there's a lot of uncertainty, there's a lot of tests, and even once the cancer is diagnosed and treated, there's ongoing supports that are required, ongoing screenings and appointments and psychosocial things going on which make it complicated for patients to go through, particularly if they haven't had medical problems in the past. Something that came out of that same survey of journey mapping in cancer care are these themes, and I think themes 4 to 6 are really reflected or seen in our uveal melanoma patients. And they're that social and emotional support is integral. It's not just nice to have to supporting patients and their families through cancer. In particular in Australia, we have problems with patients in rural settings facing logistical and financial challenges accessing treatment. Even though we've got patient subsidy, patient travel assistance, they still have to travel long distances. There's a lot of time involved in that. There's people who need support, people need to come with them, which can be very challenging. And patients really want a whole person approach to their care. One of the quotes from that study was from a patient: "If you tell me the clear picture, and even if that picture's grey, at least we're both working in the grey." And that really struck me because in a lot of these cases, we can't give patients a diagnosis straight away. We can't just take a little sample of their tumours all the time to tell them what's going on. And they like to know that we're not sure, and at least we're not sort of pretending that we know what it is, and we're all on the same page. So back to our patient journey. When they arrive at the Ocular Oncology clinic, they're greeted by a receptionist. She gives them a standard personal details and a medical questionnaire. And even that can be stressful, you know, if particularly you've come from a rural area, you're in this big clinic, everything's very slick. But, you know, we've got a smiling face behind the counter, so at least they start to calm down a little bit. So after they've filled out their questionnaire, they're directed to the waiting room. It's not usually this empty. And we try not to leave patients waiting too long, but you know, things get busy in clinics, and so they can be sitting here for up to an hour. And they're staring at this door saying ocular oncology service. And so I guess particularly for people referring to us in the same state, it's nice for you to tell the patients that they're coming to an ocular oncology service, not necessarily that they have cancer, but that it's a service that sees things that are cancer and not cancer, because just seeing that word can really stress people out before they even get to us. So once they've waited there for a little while, they have a visual acuity, intraocular pressure, dilation with our assistants. All patients get an Optos photograph, an OCT of the macula and through any lesions that are seen. And then when they come to us, they also get imaging with a slit lamp camera where relevant. And so again, things that are very routine for us, having patients have photographs, we don't really think of, but again, if they've been referred from a general practitioner or from a rural area, they've never seen any machines like this before, and you know, it can be very stressful having all these tests. They don't really know what's going on. There's lots of bright lights flashing. They're dilated, things are a little bit blurry. So it's really nice. Our clinical assistants are very good at sort of talking patients through what's happening and what all the tests that they're having. After that, finally they come through to us. We revise the history that they've already sort of given to the clinical assistant. They have an examination, and then we have a discussion with them about what we think the diagnosis is. All three of us work together in the ocular oncology service. We're not usually all in the same room at the same time like this, but certainly new patients will have an opinion from the three doctors at once, which can be reassuring. So after they come in, they have a standard sort of slit lamp examination and fundus examination, which even this as well can be stressful, bright lights and blurry vision. Kanye West's been cancelled now, so we won't stay on this slide too long. And then we come to the diagnosis and the discussion of what we've found. And once again, things start to get stressful. They hear words like tumour and melanoma is associated with terrible outcomes, even for cutaneous melanomas. We talk about radiation, and we start showing them pictures of eyes and eye models, telling them they're going to lose vision and that this might spread, and that they need to be screened for a certain amount of time. And so stress levels, again, start to rise. These are the treatment options we offer depending what's appropriate for people's tumours. Photodynamic therapy combined with TTT, local resection or endoresection, which we're doing less these days. Plaque brachytherapy in most cases is our mainstay of treatment, and enucleation. And something else from that BC study was a patient mentioned that, or a provider mentioned that true informed consent includes all options, including no treatment, which we sometimes forget. But certainly in very elderly patients, we do have some that we offer no treatment and we monitor. So after the diagnosis and management's discussed with the patient, we're very lucky to have a specialist ocular oncology nurse, Jane, who provides a little bit of counselling to the patients. She talks about what's happened in the consultation because, you know, they've really just heard these words and most of what we've said has kind of not been retained. So she goes through more questions with them. We give information sheets, contact details for follow-up, and we talk about potential surgeries if they're having plaques or enucleation, and they're sent for a whole body PET CT. So if we follow somebody who's having plaque treatment, as I said, is one of the more common treatments that we do. Sometimes they're waiting up to 4 weeks for treatment at the Mater Hospital, just simply because we have so many patients needing plaques. But I think when they finally get to the hospital for their treatment, it can be quite exciting because they've just been anxiously waiting, knowing that there's cancer. So this is the day surgery unit in our hospital. Things start to get stressful again. There's a lot of people that they see on the way before they get to the operating theatre. There's a nursing assessment here. If they're lucky, a nice doctor comes to put some dilating drops in. And then finally it's time to come through to theatre. Again, if people haven't had operations before, this is high stress. So most of our patients will have a general anaesthetic for the insertion of the plaque. And then they have their plaque. So that's the end of my Hollywood career. So I'm just going to finish up with a few little other papers looking at patient outcomes and patient experiences, because it's been a sort of in vogue topic over the past couple of years. This is a paper from Bertel D'Amato's group published a couple of years ago, looking at the patient's experiences in the US. 1/3 of patients reported that their melanomas had initially been diagnosed as a nevus, and most dissatisfaction of care was with the lack of psychological counselling, and this was particularly reported by females. And many patients complained about ways ophthalmologists delivered bad news to them. So we've got Romani here today who's going to talk about delivering bad news, which I think we could all do a little bit of practicing on. And somebody who participated in this survey said the main thing they wish they'd done differently is that the ophthalmologist who first photographed my nevus should have told me that there was a chance, however small, that it would become a tumour, and that's why I should have it watched. Even though he told me to come back in a year, he basically told me it was nothing to worry about, so I didn't go back for 2 years. And I think this is something even we can learn from. A lot of nevi look very benign, but there still always is a chance that it can grow, and I think it's really important that we mention this to patients so that there's a fine line between scaring people and worrying them for nothing, but I think it is worth mentioning to people that this can become a tumour, because a lot of patients say that it was never mentioned to them. Another study looked at patients' concerns after treatment, whether they had enucleation or plaque. The patients who had enucleations complained mostly of a loss of stereopsis, as you would expect, and concern about their appearance, and then later on concern about metastatic disease. Whereas patients who go down the plaque pathway worry about local tumour recurrence. They can have diplopia and headache that can persist. Interestingly, in the same study, looking at moods and quality of life after enucleation or plaque brachytherapy, you can see in the graphs here, a lot of them are very, very similar, and it's really only functional well-being that separates them there. The FACT-G, Functional Assessment of Cancer Therapy Scale, incorporates a lot of these factors into it, and it's slightly better in the radiotherapy group, but a lot of people think that maybe having an enucleation would impact a lot more, but they really have similar long-term outcomes in all of these settings compared to plaque brachytherapy. So what are the predictors of distress in prognosis? The most reliable predictors of distress are people who have a younger age, who are in good physical health, those who've self-reported visual or ocular symptoms, those with functional impairments, those with reported secondary glaucoma, and of course those with metastatic disease. And prognostication is something that we're talking about more and more now that we're learning more about the tumours, the melanomas and genetic details. People want to know their prognosis to inform their procedural choices and to resolve uncertainty. As we know, most primary uveal melanoma tumours are treated successfully, but up to 50% of people will develop or later die of metastatic disease. We offer most of our patients prognostic testing via a biopsy at the time of plaque brachytherapy. And there's been a couple of large prospective studies which have shown that poor prognosis is related to consistently elevated anxiety, depression, and worry about cancer recurrence, compared to good or having no prognosis. People who are given a good prognosis don't really have a different outcome, a different level of anxiety to those who have no prognosis. And interestingly, studies of people who have monosomy 3 status, those who have the monosomy 3 and infer to have a poor prognosis find alternative ways of building hope for the future, and those who don't have monosomy 3 tend to not trust that outcome anyway, or that report. But of course, people want a prognosis, and they don't want to live with worry for the rest of their lives. They have intrusive thoughts, they want to eliminate uncertainty. And people hope for and expect a good prognosis. It's like when you buy a lotto ticket, you think you might actually have a small chance of winning. People think it's not going to happen to them and they're not going to be the one who has a bad prognosis. But overall, they want to reduce future worry associated with uncertainty. But overall, people maybe don't consider the possibility of a poor prognosis enough when they ask for their prognoses. So it's still a difficult area, and we offer everyone to find out what their genetic details are. But it's interesting how many people just decline to know in our personal experience. So Kelly will talk a little bit more about the genetics in her talk. But that was just my talk on patient experience. Thank you.
Thank you, Dr. McGrath. Any comments or questions before we bring up Romana? Yes, thanks, Michael.
Do you do the plaques on day surgery? Is it day surgery?
It's a hospital, so they're admitted. Yeah. Oh yeah, it's not a day. It's a day surgery unit, but they're admitted to hospital. Yeah.
Yeah. I think you missed your calling, by the way. I thought that video was fantastic. I got anxious. My pulse was going up. I was just sitting, looking at the roof.
I noticed you've managed to get PET CTs on all patients, because I don't do that. And in fact, if people come with ultrasounds of their liver, which is kind of a common one that they've had done in their local hospital before they see me, sometimes they have hemangiomas and stuff like that really confuse the issue. Just wondering if everyone's doing PET CTs and I'm the odd one out, or...
Comments? Thanks, Sarah.
I wanted to make a couple of comments too. I think in Liverpool, sorry, I don't mean to have my back to you when I'm answering your question. In Liverpool, I think what happens is that they do MRIs of the liver, so it's directed of the liver. They don't do the PET scans. But if the patient comes with an ultrasound, I think they still do the MRI anyway, because there could have been a delay between And I just wanted to make a comment. I don't know whether you record the conversation between the consultant and the patient, because that's something that Bertel D'Amato initiated in Liverpool and which is continued. And the patients find that very useful to play back that, to try and understand all those words that were spoken to them, and also play to their relatives. So that they can then ask further questions if need be. But I think that is still a very good thing to do.
I think it's a great idea. So I know that Bertel's done that during his whole career. The only real... we don't like to see a patient on their own, because the moment you see a patient on their own and you mention the word cancer, they hear nothing else. So we always to make sure that the relative is there with them. I think the idea of recording the conversation is a good one. We don't do it, but I think the idea of recording the conversation, if they can play it back, is an excellent one. But having said that, we've got a couple of secret weapons, one sitting just behind you there, Jane, our oncology nurse. And so once they've seen we three, I should acknowledge Dr. Warrior here to my right, as well as Dr. McGrath, then they're seen by Jane, and Jane, we might spend, I don't know, half an hour, 45 minutes or something with the patient. Then Jane will spend another hour at least, and a number of phone calls, and so she's our secret weapon that we use to make sure that people are informed as much as possible.
I think Liverpool has a Jill, not a Jane. And just one last thing, I think on Monday, that Lindsay, you raised about prognostication. I'm presenting something about that on Monday, the controversies.
Oh, good. Oh, good. Thanks. Thanks, sir. Thanks very much indeed. I'd like to introduce Romana Bad. Now, some people have secret weapons at a phone. Romana's on my speed dial. Romana's probably one of the best psychologists I ever worked for. I get a lot of people ringing me from the bush. I come from the bush saying I've got a son or a daughter or a husband or wife that's having issues. Can you recommend somebody and have them sorted out? I make one call to Romana, leave it to me, Bill. I'll ring them, I'll sort it out. And she is incredible, and certainly with our oncology patients as well. As Lindsay's saying, this is not just about treating the disease. You have to treat the patient, you have to treat the family, because it affects the whole family unit. And so having someone like Romana around is extraordinary. So Dr. Romana Bowd, strategies in breaking bad news to patients. Thank you very much.
Thank you very much. Thank you very much for the invitation to be able to speak to you all. So in terms of strategies of breaking bad news, and it's so great to hear the strategies that are actually being used at the Terrace Eye Centre, and as has just been mentioned, recording, and we'll talk about that when I go through my slides. That are not going, sorry. So some people find it difficult to give bad news to patients because A, they don't want to hurt the patient, or their feelings of failure because of the news that they're having to deliver. Sometimes a negative effect on doctor-patient relationships. There might be a barrier between the doctor and the patient. And sometimes it's the unpredictability of a patient response, such as anger, which is commonly as a result of fear. And it may remind a doctor of experiences of bad news or bereavements of their own. So these are all normal experiences and feelings. And we always recommend that doctors go and seek support if after time it starts to affect them as well. So in terms of a strategy, I teach in the School of Medicine for the Year 1 and this is actually given in Year 2. We have what's called a SPIKES approach, which is a 6-point approach to breaking bad news. And we give medical students the opportunity to give bad news in a role-play scenario where they're having to use these spikes. So spikes is setting, perception, invitation, knowledge, explore and empathise, strategy and summary. The invitation is probably the most important one there. Sometimes it's better to ask the patient if they want more detailed information after providing basic information. And Dr. McGrath actually mentioned once someone hears the word cancer or any other form of bad news, they'll stop listening. They can't hear past that point. So the setting, we obviously consider the physical context, and as was given or shown in the Terrace Eye Centre, that's the perfect setting where you've got private, quiet place, and obviously using listening skills like open-ended questions. The perception is ask the patient what they know or suspect. What did you think when? Did you think it might be serious? What has been going through your mind while you've been waiting for these results? Listen to the level of comprehension and vocabulary. The level of comprehension will affect how the rest of the interview is handled. Sometimes we recommend that people paraphrase and use the same grammar structure that a person actually has. So whilst being in a medical setting, you might be just used to using not jargon, but common terms that you might feel are common, but most people might not understand what they are. So invitation, as I said before, ask the patient for permission to proceed, because once you've given bad news, people are often shocked or fearful, and so they may not be listening past that point. During the course of breaking bad news, be guided by the patient's responses and body language. Body language is probably the most important one to watch. So watching someone's non-verbal responses in front of you, if they suddenly drop their head, or you can see a frown, or suddenly you'll see them slump in a chair, that's the time to pause and ask, would you like me to go on? Do you have any questions? In some cases, the patients may like to have a family member, and it's fantastic to hear that the Terrace always have a family member or someone with the patient, because often that person can take on more information than the patient themselves. Sometimes it's better to ask if the patient would like more information after providing the basic information. The basic premise behind this is we're trying to avoid what some people have presented later as, I didn't hear anything past the word cancer. So knowledge, use language intelligible to patient, give information in small chunks, speak slowly and clearly, check for understanding, and summarise your key points. Often silence or pause is a very important tool just to pace everything very slowly so people can absorb the information that you're giving them. So explore emotions and empathise. An empathic response is a technique, not a feeling. It's not necessary that you feel what the patient feels. Rather, empathy is an act of imagination combined with an ability to convey that understanding to the patient. I can imagine you may be feeling, not I know how you feel. Give the patient time to digest the news, and that's what I was talking about, the pause of silence of at least a couple of seconds. Respond to the patient's reactions as they occur. We use the mnemonic NURSE, name, understand, respect, support, and explore. So name the emotions, or try and name the emotions. I understand this is a shock. We were both hoping the news would be better. Respect, it is understandable that you are feeling fed up and angry. Support, we'll do what we can to help you through this. And explore, provide opportunity for further discussions. It's really important to normalise the feeling of alone. A lot of patients feel alone in this path, and as watching the video that was just given, it's quite frightening for a patient to go through those corridors and feel that they are alone, even though they're around a lot of professionals. They don't have their major supports with them. So strategy and summary. Always propose a strategy. I'd like to refer you to. There are a number of treatment options. These may include, I have not as yet made a decision. So of course, introducing as much of the strategy as you are going to implement. Close with a summary of content discussed. Offer patients an opportunity to discuss any urgent matters. Offer to write down, or as has been mentioned, record. Sometimes patients like to record their own sessions, or assessments that they're going through. So that's obviously an option. Establish a clear contract for their next contact. Offer assistance in telling others, but if they've got others with them, that obviously is very helpful. Document the information, and if there are no curative treatments, avoid the notion of nothing more can be done. Other suggestions, provide information about support services, so obviously psychologists, social workers, anyone that you can access, or refer them back to their GP so they can get mental health care plans, so they can access psychologists at that point. And obviously address your own feelings and seek the support of peers or mentors if needed. So these are the further readings, or what we refer to when developing the spikes. The book that I've got here, When Breath Becomes Air, is probably the most important resource when trying to understand this concept. This book was written by a young aspiring neurosurgeon who unfortunately was diagnosed with a serious lung cancer and didn't unfortunately finish this book. And it's his own journey along the cancer pathway where he reflects on how he delivers information, or delivered information, and how his colleagues and friends are now having to deliver information to him. It's a very deep book, but it's a very good book as well. Thank you very much for the offer to talk today.
Any questions or comments in terms of how you do it? Or I think the very important question we always ask, and by the way, the three of us normally will see each new patient together. So one of us will see it initially, and then we will come in, the three of us, with Jane, and so have a discussion with the patient. And so if there's some, in terms of the diagnosis, even the management, we'll say to the patient, well, look, there's no clear pathway here. You know, Dr. Ray thinks this, Dr. McGrath thinks that, I think that. So, but having said, putting our ideas together, this is what we think is the best approach, and involve them in that discussion, particularly with the relatives as well. But the first question I ask is, what have you been told? Because it's very important to find out what they know, because you don't want to come in on top of information that's already been provided and contradict it, even though you might not necessarily agree all the time. you're very careful how you handle that. So we want to get a baseline of what knowledge they have, what they've been told, and then from there, then you can manage the process from there. Any questions or comments to Romana, please? Dan, do you think differently?
We don't have the same level of support routinely for the sort of psychosocial management in Victoria. So, do you have support from Queensland Health sort of embedded in the system, or is this just part of the Terrace sort of network?
Basically, all the tumours in Queensland, Northern Territory, Northern New South Wales will come in through the Queensland Ocular Oncology Service.
Yeah.
So they're basically all managed in the same way, the same process.
Yeah, yeah.
And the other important thing is we've got to make sure you communicate back to you people who are referring the patients. And so it's very important that we have detailed letters. If it's something I think the patient's really in trouble, I'll ring the GP and I'll say, I've just seen Mrs. Jones, your patient. I want to let you know that she's got a very nasty tumour in her eye. He's going to need your support. This is what we're doing. But otherwise, by the time the letter gets back to the doctor, GP, who's copied into the letter to the ophthalmologist, optometrist, the patient's already been there, crying, desperately anxious across the table, and the prior GP doesn't know what's going on. So that communication is really, really important. Guy. Dr. DeMello from Terrace Eye Centre.
Given these patients are highly vulnerable, and particularly those who have a poor prognosis, is there any way to identify or any advice in trying to manage patients who are perhaps going to point themselves either at their own instigation or via a relative at inappropriate therapies, things that are actually not going to help them or potentially harm them?
Dr. Warrior, you said nothing.
Are you talking about us? No?
Yeah, quack.
Right.
Therapies.
I think, that's a really tough question because we don't really have an answer as to whether quackery works or not. And, well, there's no trial, there's no evidence. And you really, the mind is such a powerful thing. You don't want to dismiss their thoughts on that matter. That's really important. So you don't just say, oh, that's rubbish. But you're really just trying to encourage them to not leave what we're offering. So whether they want to take herbs and do all of this other stuff, I guess the way that I would approach it is not dismiss that, but try and steer them towards this tried and tested pathway and not talk about alternative therapies, but talk about adjunctive therapies. If they want to take herbs or, do hypnosis or trial Chinese medicine, I'd always encourage them to do what they feel is proper, but not to ignore what we're offering. And I guess you use the science and the evidence to try and lead them back to that pathway. And I think you're more likely to be successful and lose them to quackery if you don't dismiss that. You may think it, and we often talk about that after the patient's left the room, but it's important not to dismiss what patients feel, because what they feel, as you've heard, is actually really important and it affects their prognosis. So.
All right, next up we've got Kelly Brooks. Kelly's one of the members of the team at QIMR Berghofer with whom we work very closely for doing uveal melanoma research. She's going to talk to us about ocular melanoma tumour genetics, which is one of her pet projects.
Okay. Yes, as you just heard, I work at QIMR Berghofer with Nick and Peter and Jane. And we're very lucky to work very closely with the Terrace Eye Centre, who send us a lot of uveal melanoma samples our way, and we look at the genetics and genomics of these tumours, which are what we're very interested in. So I'm going to give you a bit of an overview of what we and other people in the field have done in this area and how we think that this has given us information about these tumours and in some regards about their prognosis and treatment options and responses as well, and where we think this field is going to be heading next. Okay, so when we look at the genomics of uveal melanoma, what becomes very obvious is that uveal melanoma is a very distinct beast from all the other melanoma subtypes. And this is highlighted quite nicely here in this figure from our recent paper, looking at the tumour mutation signatures that you observe across the subtypes. So as you can see in cutaneous, mucosal, and the acral tumours, there are quite a variation of the different mutation types in terms both in between the samples and within the samples. But in uveal melanoma, the vast majority of the tumours, I think this is actually, this pointer won't show up, but are actually represented by the one very bland pale yellow sequence, tumour mutation sequence that you can see there. And this is a very generic sequence that is detected in pretty much every tumour type across every cancer. And there is obviously one little subset of samples that are an exception to this, which I'll touch on later. But they are very silent compared to the other melanoma subtypes. This is also the case when we look at other features, including the structural rearrangements, which are the very colourful bars you can see. There's a lot of noise going on for cutaneous melanoma, acral and mucosal, but in uveal melanoma, again, it's actually relatively silent compared to these subtypes as well. Once again, in the grey bars, we can see the same for tumour mutation burden. So whereas the other cancer types have quite a high tumour mutation burdens, the other melanoma subtypes, uveal melanoma has very low tumour mutation burden, except for that small subset you can see at the far left end, which I'm going to touch on again in a minute. In fact, uveal melanoma has one of the lowest tumour mutation burdens of any cancer that has been assessed. And this could actually be a contributing factor as to why we see such a poor response to immunotherapy in uveal melanoma, as you can see here for both anti-PD-1, anti-CTLA-4 and combination treatments as well, where the responses we see are definitely not what we see in other cancers such as cutaneous melanoma and lung cancers, where we get good responses to immunotherapy. And what we know from these cancers where we do get those good responses is that there is, in general, a good correlation between a high tumour mutation burden and a good response to immunotherapy. So the fact that the uveal melanomas have this extremely low tumour mutation burden is probably partly behind this poor response. As I mentioned before on the other slides, there is this subset of tumours, which you can see at the left end of this graph at the top here, that are an exception to this and do have a higher tumour mutation burden than the rest of the uveal melanomas. Two of these in this study, this is one of our recent studies, so this is the majority of these are samples from the Terrace Eye Centre. And we had a couple of patients here that had germline MBD4 mutations as well. So this represents two samples that have a higher than normal tumour mutation burden. And this is a germline mutation that predisposes them to developing the cancer, but because it is involved in DNA damage repair as well, it also means that these tumours accumulate a high level of DNA damage. What is interesting looking at these patients is that there's been two case studies on patients with MBD4 germline mutations in uveal melanoma, one from our group and one from another group, where these patients actually had a much greater than expected response to immunotherapy. In this case, it's anti-PD-1, with progression-free survival of over 22 months in one case and over 10 months in another case, which is significantly better than the median progression-free survival that is seen in uveal melanoma of about 2.8 months. So this does suggest that having a higher tumour mutation burden in these rare cases can promote a better response to immunotherapy in uveal melanoma. The other cases that we see here that have a higher than expected tumour mutation burden are represented by these tumours highlighted black here, and these are the tumours that occur in the iris. And if you look on the graph at the very bottom, you can see that these tumours have this pink tumour mutation signature that we don't see in the rest of the uveal melanoma tumours as well. This tumour mutation signature is actually associated with UVR, or sun exposure and sun damage. The vast majority of uveal melanomas do not get any sun exposure or sun damage, but obviously the iris ones where they're located are still exposed to the sun and they do get sun damage. And this creates a much higher tumour mutation burden in these tumours and makes them somewhat distinct from the other uveal melanoma tumours. While the iris melanomas are generally thought to have a better prognosis, half of the patients that are represented in this study did actually have metastatic disease or progressed metastatic disease, so they do sometimes require treatment. And it could be the case, as it is for MBD4, with this higher tumour mutation burden, that these patients would be more responsive to immunotherapy as well. In terms of all the sequencing that has been done, one of the other factors that have come out is obviously identification of recurrently mutated genes. And once again, compared to the other melanoma subtypes, there are relatively few of these compared to the others where you can get large numbers, 20 or more, and we only have about 10, if we're lucky, that are recurrently mutated in uveal. The ones that everyone is very familiar with, I'm sure, are GNAQ and GNA11, And they function in the same pathway as CYS-LTR2 and PLCB4, which were more recently identified to promote the oncogenic signaling that is really critical in uveal melanoma. A mutation in one of these targets can be detected in nearly every uveal melanoma tumor sequence, so it's very crucial to uveal melanoma. However, that it does not segregate with prognosis, gives us no information on that. And currently, we do not understand enough about what happens downstream of these targets to effectively target them for treatments in the same sort of way that in cutaneous melanoma, for example, targeting BRAF and MEK inhibitors work somewhat for the oncogenic signaling. There has been no such success with these targets in uveal melanoma. The other genes of note are the uveal melanoma drivers, primarily EIF1AX, SF3B1, and BAP1. Now, these three genes do actually segregate with prognosis, as you can see in this graph over to the left, with EIF1AX having very good prognosis, SF3B1 being more intermediate and associated with late metastatic progression, and BAP1 being the worst prognosis and associated with early metastatic progression. The reason these three genes are of particular interest and why they likely segregate with prognosis fairly well is because all of these genes are actually epigenetic modifiers, which basically means instead of all of the changes that we observe that can give us information about the tumors happening at the genomic level where we've been looking, they're actually happening at lower levels in the cells through all the signaling. So these three genes have a lot of potential to control vast amount of signaling within the cells that could be directly linked to metastatic progression that we're not seeing at these higher levels of genetic analyses that we have done. In terms of prognosis in uveal melanoma, a lot of the sequencing studies that have been done to date have been able to show many ways in which the sequencing data can be used to classify the tumors into different prognostic categories. One of the most famous being this study here from TCGA, which is summarized here. This is through looking at things such as copy number, mRNA levels, DNA methylation, and a lot of other factors. The majority of this classification is, however, very reliant on mutations in those genes that I just mentioned, and also in chromosome changes that we're all probably very familiar with, particularly chromosome 3 monosomy and 8q amplification. So a lot of these factors are things that actually feed into tests that are done clinically to look at prognosis, including MLPA, that's very much associated with the chromosome changes, and even the gene expression analyses that are done primarily in America to do with changes that are based on, a lot of them are based on chromatin, the chromosome copy number changes, and also genes that we know are actually controlled by these three genes I mentioned, EIF1AX, SF3B1, and BAP1. Now, while this genetic information does give us a lot of information about patient prognosis and which ones are going to progress, as you can see here, a lot of the treatment modalities that have been trialed in uveal melanoma still have very little effect. So there is a lot more that we need to do to understand what is going on in these tumors and how we can translate this into better treatments for uveal melanoma. And we need to start looking at deeper levels of sequencing in uveal melanoma. And this is where single-cell sequencing analyses are going to start coming in. This is a new sort of technology that has been rolled out across many different cancer types, and there's been a couple of studies so far in uveal melanoma. What this does different to the sequencing I've shown you before is instead of looking at the tumor as a whole and basically getting one readout for each gene, it looks at individual cells within the tumor. So this gives us information on the tumor microenvironment, what cell types are present, but within those cells you can also look at things such as the chromatin structure of them, so this gives us an indication of how expression is being controlled, the gene expression within those cells, so which pathways are being turned on, and also you can look at proteins on the outside of these tumor cells as well, which gives us lots of information in particular about the immune microenvironment. So this figure is the example from 11 samples that was done in this first paper to come out in uveal melanoma, and you can see they could identify a lot of cell types here, including blood cells, RPE cells, a lot of immune cells, and a lot of cancer cells, which on the right they have tried to cluster into some of their prognostic categories, which I'll touch on in a minute was a bit limited in this study to actually be able to delve into any of that metastatic signaling. But one of the interesting things that did come out of this paper was when they were looking at the exhaustion markers on T cells. So most of the immunotherapies that are being used are targeting PD-1 and CTLA-4. And as you can see on the T cells here, the expression was actually quite low in uveal melanoma, which could also be partially responsible for why we see such poor responses in uveal melanoma. Instead, they did identify that LAG3, which is another exhaustion marker, had higher expression in uveal melanoma. And this is another target that has currently been developed in other cancer types for immunotherapy. So it'll be interesting to see if this translates into a better immunotherapy for uveal melanoma down the track. In terms of better understanding what's going on in the metastatic setting and progression, as I mentioned, the study that was done on the 11 samples here didn't have much genetic diversity in terms of the prognostic categories. 11 of the, out of 11 tumours, 8 were BAP1 negative, 2 EIF1AX, and 1 was SF3B1 mutant. There's been another couple of studies, each had 6 samples each, and 4 or 5 of the 6 samples were also BAP1 negative. So the studies that have been done to date have not had the diversity in these prognostic categories to really help identify what is going on in the metastatic signalling. And this is what we're hoping to do in our future work. So with some very tireless effort from the team at the Terrace Eye Centre, we have over 50 samples that we've got stored ready to go on these analyses. And we're going to be looking for fairly equal representation between these 3 categories that are represented by mutations in these epigenetic modifiers, BAP1, EIF1AX, and SF3B1. And by doing comparative studies at this very detailed level of sequencing analyses, we're hoping to really be able to hone in on that signalling that is directly responsible for the tumours being able to progress to metastatic disease. This will hopefully help us identify some pathways that can be used to target and maybe even be explored for avenues of maybe blocking metastatic progression in the future. The other thing we're very interested in looking at is we've been very lucky to get some matched tumour and normal uveal tract samples as well. And the exciting thing about this is that this will give us detailed information on the biology of the normal uveal tract, in particular normal uveal melanocytes. Because as I mentioned, we don't know a lot about what they are doing in the uveal tract where their primary role is not in sun protection. But having these paired samples as well will give us some very clear data sets to actually hone in on what that oncogenic signaling is doing in better detail. And this signaling is present in nearly all of the uveal melanoma tumours, as I mentioned. And through a better understanding of this, we might be able to actually develop some targeted therapies that can be implemented in a similar way to BRAF and MEK inhibitors in cutaneous melanoma. And while there was a lot of problems with them in adaptive resistance in cutaneous melanoma, the relative genomic silence and stability of the uveal melanoma genome that I mentioned before could actually work into the favour here, as they're unlikely to be as easily able to adapt and create resistance to these treatment approaches in uveal melanoma. So that's where we feel that the field is heading. So just to summarise, all of the sequencing that's been done so far, studies have given us a lot of information on the tumours, how they form, what helps contribute to them, and their mutation landscapes, and we can get a lot of information from this that can help with prognostication. In terms of treatment outcomes, it gives us very little influence on the treatment outcomes at the moment, except for tumour mutation burden. We know that MBD4, high tumour mutation burden, does seem to have a good response to immunotherapy, and this could be the case for iris tumours as well. The future insights are likely to come through this more detailed sequencing and single-cell sequencing space. We've already got some indications that this might help us identify better immunotherapies, and we're really hoping that by larger and more diverse genetic subgroup sequencing comparative studies, we're going to be able to really hone in on this metastatic and oncogenic signaling as well. So I just want to thank everyone who's been involved on this slide in some of the studies we've been doing over the years in our group, and then a lot of which I presented today, and I'm happy to take any questions.
Sarah, do you want to make a comment, Sarah, before you take questions? Put the pressure on you.
So great work, Kelly, and you presented it recently also at the QOM meeting virtually in Edinburgh.
Yeah.
I think it's certainly the way to go, to concentrate on the metastatic tissue. That's exactly what we're doing as well, as you probably know. We've had a study where we looked at the paired primary metastatic tumours, just looking at SNP analysis. Mm-hmm. But at that stage, we didn't have the opportunity to do what you're doing with the single-cell analysis, which will be very exciting. And I think you're perfectly right with respect to our understanding of normal choroidal melanocytes, what they're doing. We actually had a PhD student set on that at the moment, the understanding embryology of the melanocytes, how they migrate into the eye, what they're doing there. And it's only probably through that then we can understand how they undergo malignant transformation. So I think it's great work, and I'd be more than happy to help collaborate and provide you with fresh tissue if you need more choroid or metastases.
Yes, brilliant. Thank
Or
you.
perhaps one question, if I'm
Yes.
allowed. I find it really interesting with the iris melanomas. Just wondering how many you examined and whether you know the color of the irises, whether that had an influence on the mutational status of the iris melanomas. And sorry, one last question. I know it's very controversial as to whether BRAF is mutated in iris melanomas or not. Certainly not in our hands, but in other cases, in other labs, it appears to be.
Yes. I'll start with the iris color question. I know we do have that information recorded, and I believe we did look at it and didn't see anything, but I can't remember the exact details. There were, I think in that study, there was 8 patients, but I don't believe anything jumped out. I think we did look at it because we were curious if you got more iris tumors in the lighter, obviously colored iris, and if they, because that pigment would suggest they have less sun protection just off the bat, and that might be. Nothing jumped out, but I can't remember the exact iris colors at the moment. In terms of the BRAF mutations, I don't believe any tumors that show up with BRAF mutations are actually uveal melanomas. I know there'll be some people who disagree with me on that, and I know it has been seen in some of the iris ones, but I'd almost be more inclined to think they were more conjunctival rather than iris. We know that occurs a lot in there, but yeah, we definitely haven't seen any in the ones that we ourselves have sequenced.
Any other questions or comments? Kelly, thank you very much. Again, it is so important to work as a team here, and so again, working with the QIMR, we try and biopsy all our patients where possible, which is probably about 90% plus. And Jane again, and when that happens, because of Jane, our oncology nurse, who's with us both in clinic and in theatre, and she makes sure we collects the tissue, makes sure we photograph both eyes, so she keeps the pressure on us, which is great. So over to you again. Thank you.
Thanks, Kelly. Up next, we have Dr. Kathy Luong, who's a house officer at the Royal Children's Hospital. She's presenting on behalf of Dr. Jacqueline White and the team there who look after the retinoblastoma patients from Queensland. I think they have some interesting cases for us.
Good afternoon, everyone. My name is Kathy Long, and as mentioned, I'm the Senior House Officer at the Queensland Children's Hospital. I would like to thank you for this opportunity to present today with Dr. White on the MYC-N amplification in 2 consecutive Queensland patients with retinoblastoma last year in 2021. Although it is rare, MYC-N amplification is not a novel gene mutation. MYC-N amplification has been known to contribute to retinoblastoma, although often together with RB1 mutations. Today, we present 2 rare cases where there's amplification of this in the presence of normal RB1 genes. So just a brief overview of retinoblastoma. It's the most common intraocular malignancy in children. It accounts for approximately 2% of childhood cancer and attributes to 13% malignancy in the first year of life. The average age of diagnosis is between 18 to 20 months of age, where bilateral disease is diagnosed earlier at 12 months and unilateral at 24 months. Most cases are biallelic mutations in RB1. Briefly going over the pathophysiology, RB1 is a tumor suppressor gene that encodes for the protein of RB on the chromosome 13. This protein regulates the cell cycle and suppresses cell proliferation through the binding of transcription factors. It is a mutation in both alleles of RB1 in a susceptible cell that develops RB. Uncontrolled proliferation due to other mutational events or epigenetic factors leads to the development of intraretinal tumors, which can then go on to locally spread or further into the orbits and metastasize. Strong predisposition to RB tumors can develop if an individual inherits one copy of the mutant RB1 and develops a second somatic copy of the mutation in the second RB1 gene. Nearly all RBs have a biallelic mutation of the RB1 gene. However, approximately 2% of unilateral cases do not have this mutation in the tumor or in blood. Instead, these cases have a high amount of MYC-N amplification. MYC-N belongs to a class of proto-oncogenes that is involved in cell cycle progression. And so an amplification of this causes unregulated cell proliferation. A normal number of copies is 1.26. And so we can see that there's two types of genes that can cause cancer, whether it is the absence of tumor suppressors or the presence of proto-oncogenes. MYC-N amplification is not uncommon in retinoblastoma, but it is infrequent, and this tends to be lower and thus associated with RB1 loss. And so it is the absence, is when there's an absence of an identifiable RB1 mutation that this amplification becomes very important. And so clinically, we can find that there's a large unilateral tumor, and the patient usually has an early onset and presents at a younger presentation, between 4 to 6 months, with a median age of 4.5 months. This is invasive and typically into the optic nerve, and it is a very aggressive disease, as shown in these photos below. Histopathologically, we find that there are undifferentiated cells with several large prominent nucleoli. You can also find necrosis, apoptosis with minimal calcification. These features are also common to other embryonic tumors relating to MYC-N amplification, such as neuroblastoma, medulloblastoma, and Wilms tumor. It's also important to note that there's absent Flexner-Wintersteiner rosettes and nuclear molding, which is more indicative of the mutant RB1. As seen in these photos, the top photo indicates the mutant RB1 gene with the presence of these rosettes compared to the bottom image where you can see the prominent nucleoli and undifferentiation of cells. And so now I would like to briefly discuss the occurrence of the MYC-N amplification in Queensland with 2 cases. To the best of our knowledge, this is the first 2 confirmed cases of the MYC-N amplification identified by the Rabanza group. These patients were diagnosed consecutively in 2021, and they showed the amplification of the MYC-N gene after FISH analysis. We can start by discussing patient CK. So patient CK is a 5-month-old male at presentation who had leukocoria noted at 5 weeks old with no family history. Mom had presented to the GP on 2 to 3 occasions before being referred to ophthalmology. This patient was subsequently diagnosed with CT3C group E retinoblastoma in early February last year. Just want to see. There we go. So the images on these slides just show the development of a large tumor at such an early age. And as you can see from the MRI, there is a large volume retinoblastoma in the right eye extending from the optic disc associated with retinal detachment. On histopathology, the MYC-N ratio is 10.35. And so anything over 10 copies indicates an overamplification. And as I mentioned previously, normal is about 1.26 copies. I've included this patient's histopathology slides here to show the apoptosis and necrosis, and note that there are absent florets as mentioned previously. Below on the photo is the FISH slide, which shows the amplification of the green signal, indicating a significantly elevated ratio of the MYC-N. And so in summary, this patient was diagnosed with a right retinoblastoma with invasion to the optic nerve and focal choroidal invasion, thus indicating a high-risk pathology. And so this patient subsequently received a right eye nucleation on the 11th of February last year with oncology input to receive 6 cycles of the JO chemotherapy, which is carboplatin, etoposide, and vincristine. Moving on to case 2, patient SM. He was a 6.5-month-old male that presented with leukocoria and heterochromia with no family history. This was noticed while visiting in rural Queensland with his grandmother, and you can see on the photo here he has a right eye booth with associated heterochromia as well. He was then seen at the Queensland Children's Hospital and diagnosed with the same T3C group E retinoblastoma in early January of last year. And so again, just bringing up his imaging here, as you can see, it's a very large unilateral tumor, again, presenting in a very small patient. The MRI shows a mass lesion in the right eye associated with a total retinal detachment. On the histopathology, we can see that his MYC-N ratio is 9.84, and his histopathology shows, again, absent florets with undifferentiated cells with large prominent nucleoli. Above, we have his FISH slides, which again show the increased green signal indicating a lot of MYC-N amplification. And so with his histopathology, that was also considered a high-risk pathology, and so he subsequently had a nucleation on the 18th of January last year with oncology input, receiving the same chemotherapy regimen as the previous patient. And so a retrospective review of the Queensland Children's Hospital genetics was done and identified only one other patient without the RB1 mutation in the tumor. Patient CT was diagnosed with right eye retinoblastoma in February of 2008. Mom had noticed leukocoria at 10 days old and presented to the GP 5 weeks later. However, there was a significant delay in referral and diagnosis. This patient then eventually had a enucleation on the 14th of February 2008 with 6 cycles of chemotherapy. And so at this stage, given her clinical picture, we are investigating if further testing can be done for MYC amplification on stored paraffin slides as possible. And so moving forward, we can see that there's no best practice guidelines for follow-up in MYC amplification in retinoblastoma patients. And so as we don't appear to understand what other genetic changes may be present that may predispose to this tumor formation, it's unclear about the need of when or how to do ongoing surveillance for these patients. It's also important to note that the MYC amplification is also associated with other neuroembryonal tumors, such as in neuroblastoma, which is having a poor outcome. And so in summary, as we mentioned, retinoblastoma is the most common intraocular malignancy in young children. However, we've identified, to the best of our knowledge, the first 2 consecutive cases of retinoblastoma without the RB1 mutation in the tumor or blood as seen in Australia. Thank you.
Any questions for Kathy?
Thanks, very nice talk. Thanks. Would there be an argument to actually call that neuroblastoma rather than retinoblastoma in that context? Just, I'm not a pediatric ophthalmologist at all. But yeah.
Jacqueline, can you take that microphone, please?
Thank you, Kathy, for a great talk. So I think sort of looking at least from the histological aspect, it does arise in a sort of primitive progenitor retinal cell. So it's still very much a retinal tumour, at least from a histopathology point of view.
James, you want to comment?
No?
No.
No?
Haven't seen him? Okay.
I think Mike Jones, I don't know if he's here, I think since we had these cases, because obviously we were going to do this presentation last year, I think Mike might have identified one case in New South Wales, but yeah, we've only been able to find one other case where we haven't been able to identify an RB1 mutation in tumour over the last 20 odd years.
Yeah, very fascinating. Okay, thanks
Right,
very
thank
much.
you. All right, Rod, you've got an interesting case for us.
Lindsay,
Maybe.
I'd forgotten that we were doing cases, but anyway. So I thought I'd just talk about some research that we're doing, which is looking at how we can map tumour borders and why this is a bit of an issue. So carotid nevi are everywhere. It's at least 6% of the adult population, depending on the imaging technology you use. If you use wide field, you find more. And pretty much everyone that's found in the community is benign. More than 99% will be benign. So we have to figure out a way to manage all these patients safely with these tumours. Melanoma is very, very, very rare. So I've just got a couple of examples of what they look like for posterity. And I'm not sure if this is working. Is there a point? Here we go. There we go. Anyway, so this is a small little nevus next to the nerve, and this one's a small melanoma, which has got orange pigment on its surface, and there's a hint of some subretinal fluid around it. And then, so growth of a tumour, if you've got a small tumour and you don't think it's a melanoma and you're not going to treat it, or we're not going to treat it as melanoma, then the next step is to monitor these patients. As we've seen, they all need to be monitored. And what you're looking for is not anything but growth. And if you look at growth, almost always happens It can happen in two dimensions and go horizontally, or it can go in thickness. We looked at all the patients at Moorfields that were monitored for a period of time and then were treated. And again, 98 out of 99 at least grew horizontally. So if you're going to monitor for one thing, it's very rare to grow just in depth and not to go horizontally. If you're going to monitor for one thing in the community, it should be to monitor the horizontal margins. And this has been the standard of care for small indeterminate lesions forever. I've just put up here for the general ophthalmologist the risk factors and how we risk stratify these patients, which has changed over time as the multimodal imaging has improved. The most recent from the Shields group is in 2019 in retina, and these you need an ultrasound, you need autofluorescence, you need an OCT, and it's looking for thickness more than 2 millimetres on ultrasound, fluid on OCT, symptoms with your vision being reduced, pigment on autofluorescence, and ultrasound features of low internal reflectivity, and then being more than 5 millimetres wide. The important thing to know, I suppose, is that the risk of growth goes up very rapidly. You only need one risk factor for it to be 11%, but if that risk factor is subretinal fluid or orange pigment, it's 25%. So it goes up very quickly, and depending on which risk factor you have, it can be 25% chance of growth at 5 years. And that's how they defined growth. So what I find with tumours you see, often it's really easy to know where they end, but if they're not pigmented, so if they're pale lesions, or if there is some sort of abnormality of the overlying retina or retinal pigment epithelium, it can be tricky to know just where the end of a tumour is, the end of a lump is. We have at our disposal, we have lots of different ways to image these things. It's either colour fundus photography, which you take a photograph and you get the three, red, green, blue, come back and you have a photograph, and that's pretty easy. The Optos uses scanning laser ophthalmoscopy, and it's there's two wavelengths. And then you have the Zeiss Claris, which has multiple wavelengths of reflected light to give us a true colour image. And it despite having all these tools at our disposal, sometimes we're really tricky. So I think I've got some examples of ones here. So this tumour here, when I first saw the patient, when they referred to me with an optometrist, they thought that this was the tumour. But on the OCT, look, I did an OCT through the macula, and actually the tumour extends all the way down here. This is a non-pigmented, or it's pigmented in the centre and then non-pigmented at the edge. So you can see it a bit, but on the Optos, but it's not very apparent and could easily be missed if you're busy. This tumour here, again, partially pigmented, and know exactly where the edges, the borders are, can be really tricky. It's probably here, but you could make an argument that it's here. This one's gone behind, but anyway, you can see that there's, if you've got subretinal fluid, which is tracking down here, if you have subretinal fluid, again, it can make the interpretation of where the edges of a tumour are very difficult. So how can we make things better? So using OCT is very useful, so you can look at things in their depth. This was a patient that we had who incidentally had an OCT 4 years before. And fortunately they'd had that OCT before their cataract surgery, because we had this image and we could see that it definitely had grown. And so this patient was treated probably before we would have otherwise if we didn't have that old OCT, because at this stage they had no pigment, they had no fluid, and the internal reflectivity, it was less than 2 millimetres, and internal reflectivity was normal, but we knew it had grown. So OCT can be useful, but I'm doing with Peter Van Weingarten and his group at CERA is they've developed technology where you can co-register these different types of images. So you can have colour fundus photography, your Optos, OCT, infrared, all on the same piece of technology. And as you scroll through, you can have your pointer exactly where it is on all of those different types of images. So we looked at to see what was the difference that was me. So when I mapped out where I thought the edge of a tumour was on colour photo, and then with the Optos, and then this one is actually using the OCT. And you can see in this particular tumour that the variation is massive. And this is someone, I see a couple of these patients every day. So we're going to look at this further using the hyperspectral retinal imaging that Pete and his group have developed. And I'm not sure if whoever was at the presentation, the AVR presentation earlier today, would have heard his explanation of what hyperspectral imaging is. I won't repeat it. I won't do it nearly as well. But basically, very briefly, instead of having 1 or 2 wavelengths of light, so you have 30 wavelengths of light every 5 microns being shined in and then reflected. You get a spectral signature, and then you need to figure out what to do with these spectral signatures. So use deep learning algorithms to teach or figure out what the different spectral signatures mean. So we've started doing this with tumours, and we're going to continue this next year with a grant from Australian Vision Research. So we would use what I think is probably the best way, if you've got imaging, of knowing where the borders are, is when you combine all the things together, particularly having an OCT. If you've got an OCT through a lesion, you can tell where the edge of the tumour is pretty well. And so we took, to train this algorithm, we took my best estimate of where the edge of a tumour was, and then ran a deep learning algorithm with, we have 12 of these patients that had been done at the time of doing this presentation. And you can see that the hyperspectral imaging, using this algorithm, you can see that it matches quite closely where the edge of the tumours are. So we think that's quite exciting, that it may be an application of this retinal imaging technique. These are the people to acknowledge, Pete and his group at CERA, and then also my colleagues Dan and John, who we work very closely together at the idea. So sorry it's not a case, but there we go.
Thank you, Rod. Any questions from?
Comes a big John.
Right, well, I'm actually going to present a couple of cases.
Lovely, thank you.
Some that I don't know much about, and I've kind of figured that this is as good a spot as any to start trying to get a few opinions. So as Rod said, this is our group of oncologists. We started off with only one person back over 30 years ago. Sorry. I've lost my... Is this button working? So I've just lost the mouse on. Here we go. So the Iron Era is a bit older than that. This is the 150th anniversary, so we've only been going 30 years. We've now also got a multidisciplinary team. And I think one of the take-home messages from today is that once upon a time, these conditions were managed by just one ophthalmologist. Nowadays, we seem to have a proliferation of lots of different parts, and we've seen that these go from data managers to nurse coordinators, and I think, as Dan said, our psychology support we don't have. I just make a point here that one of the things that determines who's in our team is really developing care pathways, and that's one of the things that I'd like to see It's very interesting watching the care pathways that Lindsay in particular showed us. So we manage a number of conditions, primarily in adults. We deal with retinoblastoma at the Children's Hospital. And like Queensland, we've got a number of different therapies, and there likewise ruthenium plaque or radiation plaques is the commonest form of treatment and as a conservative treatment. But enucleation is certainly something that we do, and one of the take-homes that I've got from today is that we need to actually be upfront with our patients a bit more about that as a good treatment option. So I want to talk about iris lesions in younger people, and so I actually had to go and have a bit of a think about what eyes look like. And one of the things that, and we've had that talk about what does the eye colour look like in people who develop ocular tumours. So the colour of your iris is dependent upon the density of your iris stroma and the pigment in it. The short wavelengths are reflected if you've got a blue colour iris. If your iris is pigmented, then it reflects back as a much darker colour. Now, iris colour is dependent upon the number and size and of melanosomes, and these are neural crest derived cells, and unlike cutaneous melanosomes, they're contained within the cells themselves. Just going back to Rod's issue of how do we actually image these, there's more than one type of melanin. And this may be one of the reasons why we are often a little bit confused. We talk about pigmented and non-pigmented tumours, but perhaps we should be talking about tumours which contain different types and different colours of melanin, and maybe looking at these with different wavelengths will actually give us a whole lot more information and certainly increase our edge recognition here. So the eye colour is dependent upon these factors, and usually by about the 12 months of age we'll see what the long-term eye colour is. We also see quite a lot of variations, heterochromia, either sectorial or one eye to the other, ocular and oculodermal melanosis, which is a neural crest migration lesion is one of the things that we see. We also see lots of iris freckles, and these are discrete areas of pigment with normal stromal architecture. Eye syndrome needs to be distinguished, and melanocytomas are a condition that we've also got to distinguish. So where do we see iris nevi? In light-coloured stroma. Patients who've got spastic nevus syndrome are said to have a lot more. And the distinguishing feature about these is that the underlying stroma can no longer be seen through it. I'd define these as sort of contractile lesions. They will often produce changes in the iris structure, but they're not lesions which are growing or enlarging, and they can be anywhere. But they're particularly seen in the inferior iris, and certainly there is a big role of UV in both nevi and iris melanoma. So uveal lesions are not very common, but iris lesions probably are 2 to 5% of those. If we're in Victoria seeing 50 patients a year, we're seeing a couple of iris melanomas per year. They tend to be at slightly younger age of onset as opposed to the posterior lesions. Circumscribed is, you can see just a focal area. The inferior iris, as I said before, in UV is an important determinant. If they're diffuse, you can get glaucoma, and this is probably also the group that have the higher metastatic risk. It's said to be only 1% at 5 years, but almost certainly there are a number of different diseases that we're actually looking at. They've talked about why is this such a low rate compared with the posterior segment. Is it the microenvironment of the anterior chamber, or is it just simply that these are much lower size lesions? I've got 3 patients, and I've only treated one of them, so I hope to be able to take some hints home. So the first is a 9-year-old, and you can see that this is a pale iris stroma. The lesion's been first seen 4 years ago. It's visible in the lower half of the temporal iris there. And I've said that this is a nevus. It's obscuring the architecture of the iris behind it. It's coloured, but not very deeply coloured, so it will be not the blue-black form of melanin. It's a child, so we didn't get a high-frequency ultrasound on it, but this is an OCT lesion which shows that there is thickening of the iris stroma at that point, so something has happened there. We've had issues of, do we go and try and biopsy lesions like this? But this is a 9-year-old child. Do we aim to treat it? My view is that we should be observing things like this because many of them will change and grow, but not all of them progress. The second is a 12-year-old boy. This lesion detected 4 years ago. It's said to have doubled in size over the last 2 years. On the slit lamp photo on the bottom there, you can see that it goes from the iris right up to the endothelium. And on an ultrasound using a 35mm probe, likewise you can see that it extends up there. The questions I have here are, should we biopsy it? Is there a risk that we'll break bits off and it might seed into the angle? Should we excise it in total, or should we put a plaque on it? And certainly through our MDM process, the majority decision was to put a plaque on it and perhaps not biopsy it, whereas my thought is that perhaps we could just excise this in total. The last patient is one that's been seen from Queensland to WA to Victoria. It's a 25-year-old girl, multiple cutaneous nevi, and we'll get her skin looked at later. And she's had this lesion, which was initially shown up probably as just a sector pigment abnormality, but she's now gone on and developed a mass both behind and in front of the iris. This is the high-frequency scan, and you can see it's a substantially thickened lesion, and it's, as I said, both behind and anterior to the iris. You can also see that there is probably a peripheral area of the iris visible. We've biopsied that, and we're really, the cytogenomics of that are yet to come through. We then put a plaque on it. So what I've tried to do here is show a variety of different pigmented lesions in younger people. We don't know which of these are going to go on and form aggressive and progressive lesions, but certainly the 25-year-old over probably a 10-year plus time span has shown that she's had what is slow progression, but almost certainly one that I feel we should be treating. I'd like to resect the second one so we've got pathology, so we know what it is. I would propose that it may well be a magnocellular nevus or a melanocytoma, and I'm just less certain about the first case, which was the 9-year-old with the inferior iris lesion. So I hope that I've learned something about this, which is there's lots of different types of melanin, there's lots of different ways of looking at it, and in terms of treatment, we need to be treating these iris lesions because some of them are aggressive, they can develop metastatic disease, and we shouldn't just be continuing to photograph them all. Thank you.
Dr. Warrior, do you want to make some comments?
Yeah, look, I think everything that you've done so far is absolutely reasonable. So the third's a slam dunk, and I think you had to treat it.
Yep.
Whether or not you want to resect, I think, is probably neither here nor there. I think the plaque is a safe option. Did you biopsy and plaque at the same time? Is that?
Yeah, we did. We actually used a forceps biopsy. It was quite a tough little thing. I was concerned that I might end up with an excision biopsy via a narrow port, but fortunately it held on. I did note that in Queensland you were saying that you're probably doing more plaques than resections, and that's certainly probably well, certainly the experience of the newer team members in our group, but if you look at the pathology of a lot of these iris lesions which have been resected over many years, certainly there's a series done at the eye and ear many years ago, and a lot of them come back as spindle cells with no mitotic figures. But I think that if you select out a small number of these, and I know I've certainly had one which came back as 20 years ago as an epithelioid tumour with bleeding, there is a subgroup of these which are really quite aggressive, and we need to be aggressive about our treatment. The advantage, of course, of trying to cut them out is you do get pathology on them, and I think that where this is an evidence-free zone, it's small numbers, so even if you've got a clinical care pathway, I still don't think that we will be able to rely on percentages and things like that, because these are individual cases. And I think that for rare conditions like this, I think you've got to have a care pathway, and you've got to have an outcome which is going to last or be followed beyond the lifespan of the clinician. It's got to follow the lifespan of the patient. And that's the only way that we're going to find out the diagnostic ways of trying to pick up what's going on in these iris lesions. I think ultimately we should be biopsying them so that we find out long-term genomic diagnostic techniques.
So I think when you assess this, again, we're talking to the patient, and you can say, got a couple of treatment options. So what they want has to come into it. Then you've got to look at what's your clinical suspicion. So if you think, look, this has grown, like in this 25-year-old, I don't think you had any doubt that this is most likely a melanoma rather than an nevus, but it's growing behind the iris, it's sort of extended, and it's been monitored over quite some time. And then you've got to look at the morbidity of the treatment that you're offering, and they've got to be happy with what's going to happen afterwards. So if you stick a plaque on something like this, she'll get a cataract, she's got no risk of amblyopia, she'll get presbyopia when she gets a cataract, no problem. You do an iridocyclectomy in the right person's hands, that goes very well. She's going to have, a keyhole iris, and then you've got to talk about rehabilitation, et cetera, et cetera. And so if there's no diagnostic uncertainty, again, you've got to leave it to the patient. But when there's diagnostic uncertainty, then I think the role of biopsy comes in, and then exactly as you said, it's incisional. Safe thing is if you're going to take a little bit, stick radiation on top, or if you're going to take all of it, there's your answer. So I think that's really, agree with that. The first two cases that you pointed out there are really difficult. Always in children, amblyopia is the thing. So are you going to treat something that doesn't need treatment and cause vision problems down the track? And the first case, I think observation would be absolutely the right way to go, because you don't have any of those things that worry us, such as invasion into the angle or really, hopefully not a change in vasculature. I did notice that there were some blood vessels within that lesion, which would worry you a bit, but if there's no pressure rise and there hasn't been a massive change, then I think observation would be okay. And then the 12-year-old, again, a tough one. Are we getting an answer because we want an answer, or, again, what's the risk in terms of morbidity for taking that out? They're the sort of things that we would probably have that discussion amongst ourselves and then with the patient. And, like you said, there's no right or wrong.
Dan.
Just thinking about the issue of tumour seeding with biopsying the iris lesions, it was just occurring to me that there is always the option of doing the biopsy at the time of the plaque removal, and we don't really think about that very often, and it can be quite hard to fit into the theatre timing, etc. But that's a way of sort of biopsying theoretically neutralised cells that we could do, so that the cells have already been irradiated, so even if they do seed, they'll theoretically have less chance of growing.
Good comment, Dan. Jack, last question, we'll go home.
Sure. No, it was just with regards to that very first patient, the young child with the pale lesion. I didn't actually notice the blood vessels that Sunil was referring to, but I was just wondering whether or not, there was a chance that JXG, is it definitely a nevus, or whether, I'm sure they've had skin exams and whatnot.
Yep, she's had steroids and it didn't get any better, unfortunately. The JXG cases that we've had have all kind of melted away at the tip of a steroid bottle. So that was certainly one of the potential differentials. and we've certainly seen one of those about every 10 years through the Children's Hospital. Interestingly, the parents of both of these younger children are probably keener on biopsy than I would be, and kind of I can understand why, particularly with this 9-year-old, where the parents kind of feel that this is a progressing lesion, and certainly if it was on the skin, nobody would have hesitated to take it off. And I think that we will probably be doing more biopsies in future. I mean, you could put a forceps into this and trim a little bit off without that great or bigger degree of morbidity. And certainly for iris lesions, I've found that the forceps is the best, as opposed to we often do needle biopsies for our transscleral anterior lesions. But the iris ones are often tougher. They've got a bit of stroma to them. But again, we don't have a lot of, these are small case numbers. We don't have a lot of experience, and there's a whole lot of things like the cytogenetics, which we're really only starting to explore, and even our experts from Queensland don't have all the answers for us in that.
Thanks, John, and thank you to everyone. All our speakers this afternoon have been fantastic, and thanks to the audience for sticking around till 5 o'clock. Hope you have a lovely evening tonight, and we will see you all tomorrow.
That's great.